Hi everyone. It's always so funny hearing yourself being introduced in that way. I think as we go through this, I'm going to talk a lot about statistics. We've been hearing about statistics throughout the day today. I think it's really important that as we go through these statistics, they can be kind of frightening, and to not view it from a sense of being scared, but rather recognizing the importance of awareness. You can't approach any issue unless you first know that it exists. Again, and as we go through these statistics, these numbers, it's so important to remember that every statistic is a person. They're a person with a life, with family. They may be people that have been connected to you. And the stories of Dr. Pert, of Margaret, just show us that it's important to ground all of these numbers in the real lives of people. And lastly, as I go through these slides talking about these numbers, it's important for all of us to ask why. Why are we seeing that there's higher rates of cancer in certain communities? And is this just something that we're just predisposed to? There's nothing that can be done, and that's not the case. I don't want that to be something that we take away from this. There are genetic and biological reasons that impact cancer, but what can we do about those things, and how do we approach those? There also is vast social reasons, and those are the things that can be changed, and those are the reasons that why we're here, to change the things that can be changed. So as we go, I just want to ground all that I'm saying in those things. So in comparison to white women, Black women are less likely to be diagnosed with breast cancer. However, they have a 40% higher mortality rate. Non-white women tend to be diagnosed with breast cancer at younger ages, from 52 to 60 years, compared to white women at 63 years. Black, Filipina, South Asian, and First Nations, and these are Canadian statistics, are less likely to be diagnosed at stage 1 cancer compared to white women. And this is important because the earlier that a cancer is found in cancer stage, the more options people have for treatment, the less invasive treatments they have, and the more likely they are to have a greater survivorship and less sickness or death from their cancers. For Black women, the incidence of triple-negative new tumors, this is a very aggressive type of breast cancer that's more difficult to treat, often requires different modalities of treatment, is double the incidence that we see in white women. For all breast cancer subtypes, so across all stages of diagnosis and across all different types of cancers, we see that Black women have the lowest 5-year survival rates. And 5 years following a breast cancer diagnosis, only 78 of Black women will be living, compared to 88% of white women. And looking at Canada, by 2024, this has been in the past, the statistics sometimes move slower than we're able to look at them. 30,500 women will be diagnosed with breast cancer. That's 25% of all new cancer diagnoses. Cancer is something that affects us all, and breast cancer is something that affects so many of us. Okay. It's also estimated that 5,500 women will die from breast cancer, making up 13% of all cancer deaths. And from a scoping review done in Canada, it was shown that women that have backgrounds in sub-Saharan Africa have lower breast cancer screening rates. Looking closer in Ontario, in 2018, the most commonly diagnosed cancer was breast cancer, accounting for almost 30% of new cancer cases. And between 2000 and 2018, over 90% of women with abnormal mammograms had follow-up within 6 months. This is so important. Having breast cancer screening allows us to be able to know a breast cancer is existing, and the earlier that this is found, the better outcomes we see for people. And so when people are able to be screened and able to have access to screening, they're able to have that follow-up, be connected with a cancer surgeon, be connected with a medical oncologist to be able to take charge of their health. However, there are inequities in mammogram screening participations among women from 40 to 49. And the higher amounts of people who don't participate in screening are seen in our materially deprived, our lower income neighborhoods, and our ethnically concentrated communities. So think here at Kitchener-Waterloo, where are those communities? Where are people who are living in those environments and communities? And what are we doing to reach out to them, knowing the information that we do know now about the higher rates of cancer and the importance of screening? And so again, I want to bring it back to what I started with, talking about what can be done and why are we here and what can be done and the importance of awareness. Now that we have this information, now we know about the higher risk of cancer and aggressive cancers in these populations, and knowing the importance of mammography, what is next? And I think it's so important that we have our elected officials here today, our healthcare workers here today, and our just community members, and to recognize that each of us play a role. Our elected officials have the roles to create policies and programming to have culturally competent care for our communities. Our healthcare workers, and this is also a reminder to myself as I go through my training, to pay specific attention to ensuring that my racialized patients have tailored access to care. And then for us, for everyone who is here, to do things like coming to events like this today, to get this information, to be able to reach out to our friends, our families, that we have in our lives that could be affected by breast cancer, and even ourselves if this is something that it's important to be aware of, and to use this knowledge as a source of empowerment and as a call to action to continue to make change. Thank you.
So, good morning, everybody. My name is Isra Ahmed, and I'm a fourth-year doctoral student at the University of Waterloo in Public Health Sciences. So today, I'm going to talk to you guys a little bit about my research, which is looking at exploring the experiences of South Asian immigrant women, uptake of primary and secondary prevention measure for cervical cancer. So I know a lot of the discussion today has been breast, so I'd like to bring a unique perspective and shift the discussion to cervical cancer as well. So the agenda for today is the following. I will start off with some background information on my topic area. Then I'll go into talking a little bit about my research approach and design. And then we'll go into some of the methods that I've used, and I will discuss my preliminary findings as I am currently carrying out my research and I'm not completely done, but I do want to share what I have discovered so far, and then I have some concluding remarks for you all today. So cervical cancer is one of the most preventable cancer types, given the availability and the effectiveness of the HPV vaccine. However, despite the implementation of primary and secondary prevention measures, there are significant number of cases and deaths attributed to cervical cancer. So according to the World Health Organization, it has been estimated that 700,000 new cases of cervical cancer annually. Currently, it ranks the fourth most common cancer worldwide in women. In Canada, cervical cancer statistics are not reported according to race or ethnicity, which is instrumental in providing a clear picture and a nuanced understanding of health disparities that exist. In the US, where data is reported according to race and ethnicity, the findings illustrate that racialized and ethnic groups hold a higher disease burden compared to non-racialized groups. It's imperative to examine uptake for HPV preventative measures to develop a comprehensive understanding of why these disparities exist. Daniel and researchers found that Black women were 30% less likely to receive a single dose of HPV vaccine compared to white women. Similarly, when looking at screening, researchers found that uptake was 28.9% lower among immigrant women with minority status compared to those who were Canadian-born. In Ontario, South Asians comprise a large proportion of visible minority groups. Many have immigrated from various countries within South Asia. Many countries within South Asia don't have a standardized integrated HPV vaccine schedule. It remains unknown whether these individuals who have immigrated from these countries are protected against HPV. Furthermore, the experience of South Asian immigrant women accessing HPV vaccine isn't captured within the literature, highlighting a wide research gap. We're looking at secondary prevention. There is limited research that is available that indicates that cervical cancer screening uptake is low among South Asian immigrant women when compared to other minority groups. Studies have found that South Asians have the lowest level of participation rates within Ontario's cervical screening cancer program, indicating a large subset of women are not being screened. The current literature does not identify factors that shape the participation of South Asian women accessing cervical cancer screening resources. And therefore, the goal of my research is to investigate the experiences of South Asian immigrants accessing primary and secondary prevention measures for cervical cancer. The main objective of the study is to develop actionable recommendations that knowledge users can implement to promote the uptake of primary and secondary prevention measures. And the overarching research question that is guiding my study is what are the experiences of South Asian immigrant women accessing primary and secondary prevention measures for cervical cancer in the GTA? More specifically, I'm looking at what are the cultural, religious, and systemic factors that shape the experiences of South Asian immigrant women accessing the HPV vaccine. I'm also looking at what are the cultural, religious, and systemic factors that impact the participation of South Asian immigrant women in Ontario's cervical cancer screening program. And finally, what are those resources, programs, and policies and resources South Asian immigrant women require to improve the access to primary and secondary prevention measures for cervical cancer. So the methodological framework that will be guiding my study is participatory action research. And CAR is the fostering of collaborative partnerships with participants that include community members, activists, and researchers to produce findings that can be used to cultivate social change. The approach includes the co-construction of research by involving multiple different individuals, and I personally have fostered partnerships with the Canadian Partnership Against Cancer and the Canadian Cancer Society. The scope of the study is at a local level, so it's going to be taking place in Ontario. A large proportion of South Asian immigrants reside within the GTA, and the cities that are home to two large populations include Brampton with 44.3% and Mississauga with 23.3%. And so this is where primarily I've been recruiting my participants from. And to ensure that the target population is accurately captured, there are several different characteristics that I have considered when looking at my target population. So number one, they have to be from the region of South Asia. So this is anybody whose ethnic roots are from South Asia. So these are people that live in countries and have immigrated from countries from Afghanistan, Maldives, Sri Lanka, India, and Pakistan. And then participants must be first-generation immigrants from South Asia. They must have a cervix, and I'm looking at about individuals from 18 to 59 years old. Participants will be recruited, are being recruited using propulsive and snowball sampling. And in terms of my data collection, I am using semi-structured interviews, and I'm conducting approximately 15 to 20 just to gain an enriched understanding of the topic area. So the best way to learn about individuals within communities is really like immersing yourself in those experiences. And so for my study, I really wanted to make sure, instead of just handing out a survey, to really connect with those members of this community, and also being South Asian myself, I wanted to use my positionality as a South Asian immigrant woman, and my parents being immigrants. I wanted to really use that lens to conduct my research with my target population. So the data will be analyzed using thematic analysis, which is a method of analysis where the data is thoroughly reviewed in a meaningful way. This process involves reading through the interview transcripts to identify recurring patterns and ideas. These recurring patterns are then grouped into broader categories known as themes. Based on these themes, meaningful and well-supported conclusions will be drawn. So although the study is still underway, I wanted to share some of the findings that have emerged so far. So one of the things that I've noticed is that there's a lack of knowledge and awareness of primary prevention. This is evident as 76% of participants who were interviewed thus far were not familiar with the HPV vaccine. So when I asked them about it, they had no idea what that was. Demonstrating a lack of knowledge plays a pivotal role in the uptake of primary prevention. In addition, participants expressed the importance of wanting to understand the risks associated with the HPV vaccine, its potential side effects, and its effectiveness before considering vaccination. A widely held misconception among participants was that vaccines could pose a threat to their fertility. As a result, demonstrating that misconceptions can reduce uptake. Other factors that have been identified to limit uptake include cost, poor doctor-patient relationship, notions around primary prevention being deemed as unnecessary, as a lot of these individuals have immigrated from countries where prevention is really put on the back burner, and so they haven't really been exposed to any sort of prevention because their healthcare systems are really focused on curative versus prevention. And when looking at secondary prevention measures such as Pap testing, some common factors that prevent uptake include a lack of knowledge of the importance of Pap testing, perceptions related to the test being uncomfortable or painful, anxiety around testing outcomes, unfamiliarity with system navigation, and physician preferences. These are some of the key findings that have emerged thus far. The findings of this investigation serve to improve access through identifying challenges that South Asian immigrant women encounter when accessing primary and secondary prevention measures. Based on the findings that have emerged, recommendations will be developed in the hopes to reduce cervical cancer mortality and incidence rates among the South Asian community. Though the findings of the study is focused on one specific racialized group, they serve as a foundation in stratifying cervical cancer measures according to race, which is a practice that is uncommon in Canada. These findings serve as building blocks for oncology delivery that is inclusive and equitable, that is reflective of the diverse patient populations within a Canadian landscape. And that's what I have for you guys today.